All right, welcome everybody. I am your host today. My name is Joanna DeBoe, and I'm a program coordinator at Proceed's National Center for Training, Support, and Technical Assistance. I also have my colleague here with me, Shay Martinez. She's in the background helping me a little bit. She's going to be a panelist today, so you won't see her or hear her, but she'll be managing the chat and the Q&A boxes. We're both very happy to have you here, and we're spending the next hour and 15 minutes with you on this webinar. Today, we start our 2020-2021 webinar series titled Raising Voices. This series is focused on raising the voices of those vulnerable populations to increase awareness, reducing health disparities, and discuss how the social determinants of health affect these populations across the United States. Today, we're discussing the high maternal mortality rates Black women face. For this, we have a very special guest with us, Dr. Denise Anderson. So let's get started. Dr. Denise Anderson holds a Bachelor's of Science in Human Ecology with a concentration in dietetics obtained from the University of Maryland Eastern Shore. She became a registered dietitian in 2002 and received her master's in public health from Rutgers University School of Public Health. She recently completed her doctoral degree in a joint Rutgers and NJIT PhD program in urban systems health track. Dr. Anderson is a National Center for Quality Assurance, patient-centered medical home certified content expert. She has over 15 years of experience in public health, including in teaching. She's a CDC Public Health Prevention Specialist Fellow and an Eagleton Institute of Politics Fellow. She's the founder and CEO of Denise Anderson Associates, LLC, an independent public health and healthcare consultancy business. She began service at the New Jersey Department of Health in May of 2019 as Managing Director for the Office of Primary Care and Rural Health. In June of this year, she accepted a promotional position as Executive Director of the Maternal Care Quality Collaborative, where she is working to reduce health disparities in Black maternal and infant mortality and to realize First Lady Tammy Murphy's vision of making New Jersey the safest place to give birth. Just a little housekeeping before we get started. This webinar is being recorded. The recording, PowerPoint, and the resources will be shared with you afterwards. Your microphone has been muted, and it will remain so for the duration of this webinar. If you have any questions during the presentation, please type them into the question box in your Zoom panel controls. I'll bring them up during the 2 Q&A sessions we're going to be having during this presentation. Also, in your control panel, you can find the audio settings and the chat box to communicate with us and other attendees, both publicly and privately. If you have any questions throughout the webinar, please chat with Shay. She will be more than happy to assist you. The webinar series that we're presenting is part of our SEBA for Health Equity program funded by the CDC. Please use our hashtag #ProSEBA for Health Equity, and follow us on social media to spread the word about our services and content. So without further ado, let's get to know each other. And we're going to launch 3 quick polls so we know who is joining you and where are you from. So the first poll, we want to know in which region of the United States you are located. You can choose between the West, Midwest, South, Northeast, and the Caribbean. All right, I'm going to allow 3 more seconds before I close the poll. All right, 3, 2, 1. So we have 47% from the Northeast, 37% from the South, 13% from the Midwest, and 3% from the West. Welcome. The second question is, we want to know what type of organization you represent. If you're a hospital or medical group practice, community-based organization, government agency at all levels, healthcare clinic, or other. And if you select other, please put it in the chat. All right, 5 more seconds. 3, 2, 1. All right, we have a great variety. Over 50% of you are from a government agency, either local, state, or federal. 33% of you are from a community-based organization, and 7% are from hospital, medical group practices, or a healthcare clinic. And the last question we have is about what best position represents you within your organization? Are you in a leadership position, mid-management? Are you frontline, clinical, or non-clinical, or other? And if you select other, please let us know in the chat. All right, 5 more seconds. All right, 3, 2, 1. Great. 42% of you are mid-management. We have 35% non-clinical frontline, 13% leadership, and 10% frontline clinical. This is great. Thank you. Okay, so today's objectives are on the screen. The goal of this webinar is to examine how the past and the present institutional racism and social determinants of health have impacted maternal mortality rates among Black women, regardless of their socioeconomic status, indicators, and access to care, and to describe a path forward for improving Black women's health outcomes. During this session today, we're going to have 2 Q&A sessions. So do not wait until the end to send us your question. You can go ahead and put them on, and we're going to have a pause for that throughout the middle and at the end. So without further ado, I am going to give the microphone to Dr. Denise Anderson. Please join me in welcoming her. Thank you. Dr. Anderson?
Hi, Joanna, I'm here. So yes. It still is not allowing me to share the video, but I'm going to go ahead and get started with where we are, okay? So
sounds great.
Thank you kindly for the introduction. I'd like to take the opportunity to welcome you again to the Birth Justice, a conversation on Black maternal mortality, its contributors, and what can be done. It is my absolute pleasure to join you today in discussing the health of Black women, specifically focusing on the maternal disease and death that disproportionately affects Black women, which ultimately affects the health and stability of the Black community. Next slide, please. Okay, so this first section focuses on the history of healthcare and Black people in the United States. Next slide. In the next several slides, I'm going to discuss the evolution of the field of medicine in parallel to the experience of African Americans and Blacks in the United States, because the disparities that we see today have been interwoven into the fabric of this country. During the pre-industrial era, the field of medicine was unsophisticated. Individuals decided to practice medicine as physicians, and others shadowed and practiced with them as apprentices. The field of nursing was also unsophisticated. There was no kind of insurance at this time. Eventually, a small number of medical schools were established, and for the most part, the delivery of healthcare was as follows. Almhouses were for the poor, elderly, homeless, orphaned, sick, and disabled. Asylums were inpatient psychiatric facilities for the mentally ill. Pest houses were used to isolate people with infectious diseases like cholera. And dispensaries were free outpatient clinics that provided medical services to people who could not afford to pay. In parallel, during the pre-industrial era, Africans were entrapped and transported to the U.S. Next slide, please. During the post-industrial era, there was the development of cities, or what we called urbanization. Additionally, there was the advancement of science and technology to the medical field. Then, the medical field became what we call professionalized and legitimate. The American Medical Association, AMA, emerged initially to control medical schools. They then worked with states to establish medical license laws. And then they transitioned to galvanizing and advocating and protecting the interests of physicians. Medical education became affiliated with universities, science courses were added to the curriculum, and an undergraduate degree with entrance examination became a requirement for medical school admission. Nurses also became professionalized during the post-industrial era. Next, the demand for health services necessitated the centralization of medical services and facilities located within cities, and these became what we now know as hospitals, whereas prior to this, the practicing physicians made house calls. Next slide, please. For African Americans during the post-industrial era, Jim Crow and Black Code relegated racial and ethnic minorities to second-class citizenship after emancipation and to substandard health and education. Then there was the infamous 1896 Plessy versus Ferguson decision that legalized segregation under a separate but equal provision with the but equal clause unfulfilled. The decision reduced Blacks to the receipt of substandard health care. To address separate but equal, churches began to develop separate facilities for Blacks. And this is always where we come back to faith-based organizations being the cornerstone in the Black community. Since medical schools would not admit Blacks, medical schools for Black doctors were also created. Of course, the separate health facilities and medical schools were not as well funded as their segregated counterparts. When Blacks did interact with the segregated white medical system, there were inequalities in medical treatment. These inequalities led to racial and ethnic disparities in access to healthcare services and utilization of health services due to differential treatment. Then there was the deceptive treatment of Blacks, with the Tuskegee syphilis study being one of the more widely known examples. This study was led by the United States Public Health Service. Syphilis treatment was intentionally withheld from poor Black men for 40 years, causing pain and suffering for the men, their families, and the greater community. Next slide. Now let's examine the social determinants and how they impact the health of Black women specifically. Next slide. Healthy People 2020 defines the social determinants of health as the conditions and the environments in which people are born, live, learn, work, play, worship, and age that affect a wide range of health, functioning, and quality of life outcomes and risk. And this phrase, social determinants of health, is fairly recent. However, W.E.B. Du Bois, in his book, The Philadelphia Negro, published in 1899, spoke about the exact same social context that we are talking about today. He spoke about differential social advancement and conditions by which Black and whites lived. This difference between urban versus suburban persists today. It is indeed the differential treatment of African Americans since slavery and the separate and unequal treatment in all aspects of life, including healthcare since slavery, for which the legacy of racism matters in present-day health. Next slide, please. The social determinants of health can be categorized by economic stability, the neighborhood and built environment, health and healthcare, education, and social and community context. Next slide, please. I believe we have a polling question.
Yes, we do. We're going to launch the poll right now. So the question is, which social determinant category do you believe influences the health of Black women the most? Economic stability, the neighborhood and built environment, health and healthcare, education, social and community context. We're going to leave another 5 seconds to answer the question. All right, 3, 2, 1. All right, Dr. Anderson. So we have 31% divided on social and community context as well as economic stability, 21% health and healthcare, 10% the neighborhood and built environment, and 7% education.
Very good. All right, next slide, please. So it's important at this point to talk about residential segregation. Blacks live under a level of segregation that is greater than any other group in the United States. A study of 171 largest U.S. cities found that the worst urban context for whites was better than the average context of Black neighborhoods. Residential segregation limits access to quality K-12 education, reducing preparation for higher education and job opportunities. Residential segregation provides greater exposure to food deserts and excessive fast food restaurants. Residential segregation disproportionately markets tobacco products and alcohol. Residential segregation increases access to illicit drugs and the consequences of drug trafficking. Residential segregation exposes residents to increased crime, and it elevates exposure to stress and hardship. The effects of residential segregation produces the triangle of disadvantage, where the home, neighborhood, and school system negatively impact minority communities. At home, there could be stress, constant moving, divorce, death, and adults entering and leaving the home. In the neighborhood, there could be poverty, unemployment, and crime. And at the school level, there are poor resources and underperformance. Next slide, please. Economic stability. Blacks have higher than average unemployment rates and lower than average median household income. The financial support for Black women varies regarding having more than one income earner in the household and whether income is received by other mechanisms such as spousal or child support. And then there is the double negative of being Black and female, whereas women earn less than men in the United States for the same work. Next slide, please. Neighborhood and built environment. There is housing and the urban blight where most Blacks are hypersegregated. That includes the physical decay of buildings and spaces and poorly maintained, sometimes abandoned, and depreciating property. There are environmental hazards, such as superfunds contaminated with hazardous substances. Then there is crime, such as illegal drug trade, gang-related activity, and police brutality. Next slide. In health and healthcare, there's one form of access to care, which is health insurance in the U.S. Absent of universal health care, most Americans gain access to health care through employment-based insurance. I already discussed that Blacks have disproportionate unemployment rates. Next, there is provider availability. This can be the number of providers that accept a particular insurance, or it could be the number of providers available to provide services in urban and rural areas. During white flight and suburbanization, this is when whites left the urban areas for the suburbs, many healthcare providers set up dual offices, one in an urban area and one in a suburban area. Inevitably, when a physician or practice is dividing time between multiple places, access is simply less. Then there is the incorporation of a patient's cultural beliefs, preferences, and lifestyle goals in their preferred language that people can understand, and quality of care, where providers use evidence-based guidelines, listen to their patients, and deliver care that is respectful and non-discriminatory. Next slide, please. Social and community context, social exclusion, social stratification, social inequalities, social position, and social hierarchy all relate to access and resources. Economist Amartya Sen stated, "It is not so much what one has that is important, but rather what one can do with what one has. Social inequalities in health may be a consequence of inequalities in capabilities. For oppressed populations, it is difficult to have control over one's life and actively participate in society when your neighborhood is dilapidated and unsafe. You're unemployed or underemployed. You're harassed and killed by police. And when you regularly face aggressions while being Black and participating in everyday activities such as sitting in a Starbucks coffee shop, shopping while Black, driving while Black, exercising while Black, bird watching while Black, sleeping in your campus lounge or in your apartment while Black." Next slide. Education. In urban school districts, Blacks are more likely to be tracked to vocational classes. Bowes and Gentis refers to this as schooled by social class, whereas low-income students are taught to stay in working service class as their parents, while students of higher socioeconomic status are taught to fill the upper echelon positions of society. Black students are also more likely to be assigned to remedial education. And many are familiar with the concept of school to prison pipeline that can be determined as early as 3rd grade or 8 years old. Urban school districts are chronically underfunded, understaffed, and could have poor grading structures and curriculums. The significance of this for the health of the Black community is that education is correlated to employment, which is correlated to access to health insurance and income. Next slide, please. Now, let me spend some time talking about higher socioeconomic status Black women. Black women of all socioeconomic status are disproportionately affected by maternal disease and death. There's a lot of discussion about not having access to care, which is often linked to education, unemployment, underemployment, and not having health insurance. But for Black women of higher socioeconomic status, they often have an advanced education. They also have a higher socioeconomic status because they are most likely employed with health insurance, which lowers issues with access to care. So what is going on with Black women of higher socioeconomic status? Black women like me. What I am about to talk about isn't supposed to be a generalization for all Black women of higher socioeconomic status, but it is an attempt to talk about why the higher income for some Black women may not be as much of a protective factor as it is for women of other races and ethnicities. Research that I conducted several years ago revealed that more so than women of other races and ethnicities, Black women prefer to date Black men. In many marriages, the couple is often of the same social class. In many Black male and female partnerships, there is an education gap between Black women and Black men. The last research that I reviewed indicated that Black females outnumber Black males in college enrollment by 14%, and this is pretty old research. It's probably higher now. The higher number of enrolled Black females equate to Black women graduating at a higher rate and earning more advanced degrees. There is a lot of discussion about historically Black colleges and universities at this time. Let me take this opportunity to explain that beyond educating Black students, the historically Black college and universities serve as an opportunity for Black females and males with the same socioeconomic status or the potential to reach higher socioeconomic status to partner and marry. Research also shows that it is the Black man with the higher education, socioeconomic status that is more likely to marry outside of his race. When Black women express their dismay for the disproportionate less Black family formation, they are labeled angry Black women, but that is a different webinar. The facts are that the pool of eligible Black men are disproportionately less for Black women of all socioeconomic status. Black men have higher homicide rates. Homicide is in the top 10 leading causes of death for Black and Hispanic men and no other. Now let's talk about mass incarceration. Although Blacks are only 12 to 13% of the general population, Black men make up more than half of all prison and jail populations. So Blacks have lower than average marriage rate, higher than average divorce rate, and are less likely than whites to remarry once divorced. There are some studies that suggest that most college-educated Black women will never marry at all. A study that looked at single Black women becomes educated and with higher paying jobs, the more difficult it is to locate a suitable mate of any race. Also, the more education and higher paying jobs decreases the likelihood of finding a Black male of equal educational and economic status. So why have I shared all of this information regarding education, jobs, and marriage in the Black community? I bring it up to demonstrate that the higher socioeconomic status for Black women may not be a protective factor in maternal disease and death if she is doing it all alone without the benefits of a partner with 2 adult incomes. Her higher income has less reach. She has more to do with that higher income if she is doing it alone. The higher socioeconomic status Black woman may also benefit from the supportive services and assistance that are often reserved to women of lower socioeconomic status. And last, but certainly not least, is the fact that higher socioeconomic status of Black women is definitely not a protective factor from explicit and implicit bias. That is evident in the stories about the maternal experiences of Beyonce and Serena Williams, both married and of higher socioeconomic status. Next slide, please. There are several theories that attempt to explain health disparities based on residential segregation, minority status, and stress. The first, the risk exposure theory. This theory supports that the high prevalence of social or environmental health risk in minority communities lead to a higher prevalence of disease and death. The resource deprivation theory supports the idea that racial and ethnic minorities have disparities in health status because they are more likely to reside in neighborhoods that lack the resources that support a healthy lifestyle. Weathering hypothesis explains race differences in low birth weight and infant mortality. The health status of minorities begins to prematurely deteriorate in young adulthood. The response to long-term exposure to social and financial stress and prolonged active coping with stressful circumstances. For Black women of higher socioeconomic status, they are more likely to not have been born into a higher social class. There was stress in coping to achieve that higher socioeconomic status, and I anecdotally argue that there is stress in coping to maintain that status as well. Lastly, allostatic loads refers to the wear and tear on the body, which accumulates as an individual is exposed to repeated or chronic stress. In other words, just because Black women of higher socioeconomic status may have quote unquote made it, the stress to get there is not forgotten. It is like the body took a picture and remembered. Next slide, please, and I think we have a second polling question.
Yes, we do. And our next poll question is, which theory do you believe impacts the health of Black women the most? The risk exposure theory, the resource deprivation theory, weathering hypothesis, or allostatic loads? All right, 5 more seconds. 3, 2, 1. All right, we have a divided house. 35% say the resource deprivation theory, 27% risk exposure, 23% weathering hypothesis, and 15% allostatic loads.
Okay, very good. Thank you. Next slide. Oh, Q&A.
Yep. Yes, we have reached our first pause for Q&A. So if you have any questions, please make sure you put it on the Q&A section or the chat. We have a couple questions for you, Dr. Anderson. The first one is, do you think residential segregation also impacts the rates of breastfeeding in specific communities?
I think that it's a strong possibility, right? Because increased use or practices of breastfeeding is associated with the amount of support, right, that a new mom receives. And so if we're looking in particular areas and there's not enough support and support in the right way, and if you can find that in urban versus suburban versus rural areas, then I think that the residential segregation does impact the support that necessitates a woman's ability to successfully initiate and continue breastfeeding.
Thank you. Somebody wants to know, which theory do you think holds the most explanatory power?
That is a great question. I really think that all of them, but I had to make myself not put in all of the above in order to keep the polling questions interesting. But I think that there's no one theory, just like there's no one intervention that is going to address what it is that we're facing, right? I think that it is the perfect culminating storm of those various factors, which is why we need multifaceted interventions in order to really see a change in Black maternal disease and death.
Yes, like a lot of things in public health. It's not a one size fits all. A few more questions for you. When it comes to differences between MDs or midwives, are there differences in the health outcomes for Black women?
So that's a great question. What the research is showing now, that it seems that, the midwifery model supports more of a natural birth process, right? Not so quick to, have, different medical interventions unless it's really needed, right? Focus on more natural process, other coping mechanisms throughout the labor and delivery. And just, one of our, the word that I'm looking for, one of the things that are credited to us in the U.S., which is not a good credit, is the way that we have medicalized the birthing process. Just thinking, before there were hospitals and physicians, as I talked about in the earlier slides, women have been giving birth, since the start of time. And so the midwifery model, I think, pulls us back from being so medical in the birthing process, in which when you're not having surgical interventions, when you're not being induced, when you don't have a C-section, it lessens your risk for complications.
Thank you. And the last question we have here is, reproductive justice framework is being heavily used now. What are some specific activities that you be done through systems change or local impact in communities or resource agencies?
That's a great question, and I'll ask that we hold that question until we get to the path forward, where I talk about where it is that we need to go, and I think that it covers the concepts of reproductive justice.
Great, let's move forward.
Okay, this next section will discuss health disparities among Black women, especially pregnant and new mothers. Next slide, please. So the relationship between race and health. Poor access or differences in access to care and quality of care based on race. Minorities often receive care too late when they are in advanced disease state. The care received is often not culturally sensitive. The care received does not often take into consideration the health literacy of the population. Then there is healthcare provider bias, in which there is substandard or unequal medical treatment based on race. There is poor provider-patient communication. Racial and ethnic minorities are more likely to have no or inadequate insurance and financial resources. Racial and ethnic minorities are more likely to utilize the emergency department without a primary care provider as a usual source of care. Again, racial and ethnic minorities are more likely to live in geographic isolation with scarcity and maldistribution of healthcare providers, also previously discussed when I spoke about residential segregation. There's inadequate support services such as child care and transportation, and discrimination during the healthcare process, where minorities are more likely to be the subject of negative attitudes and stereotypes when interacting with the healthcare system. Next slide, please. Taking a moment here to define health disparities. Health disparities are the differences in the new cases, total cases, death, and burden of disease and other adverse health conditions that exist among specific population groups in the United States. Next slide, please. Defining pregnancy-related death. The death of a woman during pregnancy or within 1 year of the end of pregnancy from a pregnancy complication, a chain of events initiated by pregnancy, or the aggravation of an unrelated condition by the physiologic effects of pregnancy. This definition and the next several slides of statistics were reported in CDC's Morbidity and Mortality weekly report in September of 2019. Next slide, please. So let's talk about pregnancy-related death in the context of Black women. Black women are 2 to 3 times more likely to die from pregnancy-related causes than white women. Next slide. The disparity increases with age. Black women older than 30 are 4 to 5 times more likely to die from pregnancy-related death than white women. Next slide. Significant differences persist among women with higher levels of education. Black women with at least a college degree was 5.2 times more likely to die from pregnancy-related death than that of their white counterparts. Next slide. Black women have the highest rates for 22 of 25 severe morbidity or disease indicators used by CDC to monitor populations estimates for severe maternal morbidity or disease. Next slide. Cardiomyopathy, thrombotic pulmonary embolism, and hypertensive disorders of pregnancy contributed more to pregnancy-related deaths among Black women. With cardiomyopathy, it is difficult for the heart to deliver blood to the body and can lead to heart failure. With pulmonary embolism, we are talking about blood clots. And as it relates to hypertensive disorders, a common one is preeclampsia. Preeclampsia is high blood pressure during pregnancy in women whose blood pressure had been normal. It can lead to serious, even fatal complications for both the mother and baby. Next slide. An important takeaway is that most pregnancy-related deaths are preventable. Next slide. Before closing out this health disparities section, it is important that we acknowledge that health disparities exist in all 6 aims of the U.S. healthcare system, which are safety, effectiveness, patient-centeredness, timeliness, efficiency, and equity. BIPOC, Black, Indigenous, and people of color, are disproportionately affected by many leading causes of death, including heart disease, stroke, cancer, kidney disease, and hypertension. And now with COVID-19, this population has higher mortality rates than white Americans. A Morbidity and Mortality Weekly report released on November 2nd this year revealed that pregnant women with COVID were more likely than non-pregnant women to be admitted to an intensive care unit, to receive ventilation, to receive oxygen, and to die. And the disparity for pregnant Black women with COVID persists because although Black women made up 14.1% of women included in the analysis, they represented 36.6% of overall deaths. Next slide. This next section focuses on explicit and implicit bias in maternal health. Racism is manifested through the policies of institutions, the intentional and unintentional actions of individuals, and as a self-fulfilling prophecy of inferiority by individuals at the receiving end of racism. In other words, acceptance of second-class citizenship and what accompanies that status, hopelessness. James Baldwin stated, "To be a Negro in this country and to be relatively conscious is to be in a state of rage almost all the time." Institutional racism manifests through the policy and procedures of institutions that individuals follow. Examples include hiring practices, to whom and where housing opportunities are made available, and the structure of the criminal justice system that disproportionately affect people of color, men and women. Personally mediated racism occurs when individuals intentionally or unintentionally take actions against a stigmatized race or ethnicity. Examples include bank loan processing, police racial profiling, harsher sentencing in the criminal justice system, teachers that have lower expectations for minority and non-dominant populations, and healthcare providers that provide substandard or unequal medical treatment based on race. Next slide, please. Here is a deeper dive into oppressive experimentation and harmful policies specific to the reproductive health of Black women historically. History teaches us that during slavery, a 1662 law made the children of enslaved women the property of slave owners. Therefore, plantation owners could increase their wealth by controlling their slaves' ability to reproduce. This structural violence to Black female slaves was further exacerbated by the ban on the importation of slaves, which made the reproduction of slaves even more valuable. They had to keep the plantations going. So white men have been controlling and making decisions about Black women's reproductive health for a very long time. Black female slaves were expected to conceive and birth strong babies in addition to their daily extreme physical labor expectations. Next slide. In Birthing a Slave, Marie Jenkins Swartz described the use of a scientific approach to breeding, coercion, and medical experimentation on Black female slaves. In Medical Apartheid, Harriet A. Washington described how Black enslaved women were forced and restrained by physicians while experiencing intense pain and suffering as their genitals were sutured without anesthesia. Black women have always been viewed as less fragile, able to handle it, and resilient. Perhaps this historical context influences the voices of Black women today that are ignored when we vocalize that something is not right and that we are experiencing pain that is not normal. Personally, I reject the absolute strong Black woman and superwoman complexes. I'm vulnerable, I have feelings, I get tired, I experience pain. And I need the opportunity to be vulnerable, to be heard, and to be supported. Next slide, please. Explicit and implicit bias is alive and well in today's healthcare system and arguably manifests in more ways than we can count. I talked about the context that influences Black family formation earlier. I thought it was important to provide examples of implicit and explicit bias as it relates to Black fathers that minimalize their role as partners and fathers, ultimately affecting the health of Black women and Black babies. We have the spoken and undocumented use of the derogatory term baby daddy by nurses in labor and delivery, a study that showed that white pregnant women with Black partners were more likely to be mistreated by healthcare providers, and the assumption at times that present white fathers are automatically perceived as responsible partners, while Black fathers are automatically stigmatized as being less than responsible. Next slide, and I think we have another polling question.
Yes, we do, and this is our last polling question of this presentation. We want to know from your experiences, how many attendees have personally experienced or heard about a discriminatory experience with the healthcare system from a family member, friend, or colleague? Okay, 5 more seconds. 3, 2, 1. All right, so 82% have had that experience of heard somebody, and 18% have not.
Okay, thank you. Next slide, please. So this final section of the presentation will describe a path forward for reducing maternal mortality and improving health outcomes in Black women. Next slide. A path forward. Black women, like all women, deserve respect in their interaction in all spaces, including healthcare. Black women need compassion regarding their differential health outcomes, including maternal disease. Black women need to be heard and to have bidirectional communication with their healthcare team, not unidirectional communication. Black women need continuity of care in which their health information travels with them across specialty care, facility-based care, and community organizations. And Black women's preconception health, such as obesity, chronic hypertension, and type 2 diabetes, must be respectfully and appropriately managed to reduce pregnancy-related disease and death as well. Next slide. Women, especially Black women, need public policies that address the factors that influences health outcomes based on where people live, work, and play, the social determinants of health. To address the social determinants of health, policies must address poverty, neighborhoods, healthcare, communities, and education. Ideally, these policies should be made at the federal level, but in the interim, can be advocated for at the state level. We also need to adopt a healthcare in all policies lens, not just health policy. So what does that mean? That means that we should look at the potential health impact of all policies. How does transportation policies affect health, educational policies, criminal justice policies, environmental policies? We also need to reduce unintended pregnancies by making birth control options such as LARC, long-acting reversible contraceptives, more widely accessible. And we need implementation of standardized protocols that require examination of reported signs and symptoms. If you are following protocol for signs and symptoms, then you are acting according to evidence-based guidelines, regardless of any other socio-demographic factors. These evidence-based protocols, checklists, triggers, and simulation trainings, coordinated care, resource management, training for staff, credentialing, and just the overall promotion of a safety culture is imperative. The reduction of peripartum racial and ethnic disparities patient safety bundle is one such example. This was created by the Council on Patient Safety in Women's Healthcare and the Alliance for Innovation in Maternal Health. Next slide. Black women need shared decision-making tools to help prepare them to make informed, values-based decisions with their care system. Shared decision-making aids provides detailed information without advising the audience to choose one decision over another. I believe that the use of shared decision-making tools will help build health agency in Black women. Jennifer Praruga defines health agency as the ability to engage with and navigate one's environment and the healthcare system to prevent disease and death and to meet health needs. Then there is addressing explicit and implicit bias, which involves assessment and revision of institutional policies. It also involves ongoing assessment, training, and skills building of healthcare personnel in the identification and mitigation of explicit and implicit biases that we all have. Next slide, please. And at last, I'd like to end by discussing consumerism in reducing maternal disease and death. Consumerism defined is the protection of the interests of consumers. We need more discernment in who we allow the privilege of taking care of our health. Now, I recognize that the choices we have in the U.S., absent universal health care, is controlled by having insurance and what is covered by the insurance company. So I am advocating that we optimize controlled choice. Let's think about the time that we put into researching the purchase of goods such as television, cell phones, and laptops. We need to use what is out there to help us in making decisions about who we select to provide our healthcare services. We should be looking at Yelp, health grades, Google reviews, etc. We should have expectations about what good delivery of healthcare should look like and not settle for less. Non-traditional days and hours of the week, appointment availability, electronic submission of prescriptions, patient portal, staff that pick up the phone when you call, and a provider that calls you back within a respectable amount of time. Whatever is important to you and your family, don't settle. What is the saying? Believe what a person shows you the first time. Believe when a provider does not meet your needs the first time. Do your research and make a change then. It is much harder to change providers when in the midst of a health crisis. So when your care has been unsatisfactory in your normal interactions, don't trust them to be different during a crisis. Lastly, I will leave you with this sentiment shared by Brown and colleagues that resonates with me. The health system will transform when patients, as consumers of healthcare services, use their experience to select providers. When employers and purchasers use patient experience to design benefits and payments, and when medical staff and administrators act on patient experience to improve healthcare practice systems and care. Next slide. Thank you for participating in today's webinar to discuss this important and relevant topic of Black maternal health. I will now turn this over to Joanna to help facilitate questions and answers.
Thank you, Dr. Anderson. This was very eye-opening and a lot of very good information. We have some great questions for you. Somebody's asking, how important is it for Black women to have health providers that look like them?
It's just extremely important, right? We know that the research shows that Black women, Black people, just racial ethnic minorities in general do better when they're receiving services from racial and ethnic providers that look like them. And this isn't just in healthcare. This is throughout, right? They say the same thing about education, that minority students thrive more when they're being taught by teachers that look like them. And so this is just the overarching theme. The issue becomes the availability. It seems to be extremely hard to identify that. I probably maybe a year and a half ago went to switch my provider, and I just kept Googling, woman of color primary care provider in my area. I finally had to reach out to a colleague because I knew what health system that I wanted to receive my care and ask for a recommendation. It just seemed like it was so hard. How can I find a woman of color that has, office hours Monday through Friday, but late evenings and maybe the occasional weekend? I want to make sure that I can receive that my prescription can be electronically sent and that I don't get a hand prescription, have to take it to the pharmacy and wait for my prescription. I thought that they were very basic asks. But apparently it's very hard because it's just not as many providers of color as there is the demand. Great question.
Yes, and I agree with you. And here at PROCEED, we work a lot with the class standards of cultural and linguistic appropriate services. And it's not just the health providers, it's everybody across the health system. We're looking at, from the reception to the images on the wall, to the nurses, even management. We want to see, this diversity and people that look like us across the board. So it is so, so important.
Agreed.
Are there any differences in rates when it comes in comparison between African or Black immigrant women versus first or more generation American Black women?
That is a great question. And the issue is that most people aren't collecting race ethnicity data broken out by that way, right? It's amazed to see how many folks still aren't collecting racial and ethnic data overall. But in general, when they do, they collect the data according to like the U.S. Census Bureau, in which the categories are very limited. And so it's that one category, Black or African American, which is a catch-all. And, it's not all the same. There are ethnicities within the Black race. And so I am so sure that there are, differences in outcomes, just like there are, different cultural expectations and needs. And so, we're just not at that place to even be able to collect that data on a broad basis to look at what those differences may be. And that's important. Thank you for that question.
Yes, and I completely agree with you. It's unfortunate we're not there yet, but hopefully we'll get there soon. Going back to talking about the importance of the father and the partner in the life of Black women and all women, what are the statistics talk about when it comes to treatment or the outcomes for Black women that have a white partner?
Yeah, that is another interesting question. I mean, this is one of my passion areas for research, and I haven't had the opportunity to dive into it for some time, but that is the question, right? Whether or not we are truly seeing an increase in Black women dating men of other races and ethnicities. I can say that anecdotally, I feel like I see it more, right? But I haven't dived into the research to see if that is an actual, significant change. If there is more of an increase of Black women being willing to, date and marry outside of their race.
And when it comes to mortality rates for these Black women that are dating Black men or they have Black fathers, is there any difference that we know of or not yet?
I haven't seen any data that shows that.
Okay. Since we have a lot of people that are not necessarily physicians in the presentation today, can you tell us how can non-physicians help Black women? We're talking about from coworkers, family, community-based health workers. How can somebody that is not a provider can help Black women to be heard and pay attention to what's going on to reduce this rate?
Absolutely, because, I would argue that, your space as being non-clinical is just as important as the clinical, because I talked a lot about the social determinants of health. And so wherever it is in your capacity that you are able to be a listening ear, that you are able to help to identify resources for Black women, when you're able to help them navigate the various systems, provide resources for support services, let them know, where they can go when they have a complaint. There's a system, there's a way that we can go about doing these things, and I'm not sure how widely it's understood. And I know that it also varies by state, right? But in the state of New Jersey, you have several mechanisms, right? If you have encountered an inappropriate experience dealing with any type of discrimination within the healthcare environment, I just feel like most people think about putting a report or a claim in when it's dealing with medical fraud, but you can, look to, for sure, do a facility-based complaint, right? At least within hospitals, there's usually some type of, patient advocacy unit or department for which you should be able to launch a complaint against, discriminant behavior. Then there's the opportunity to work with your Department of Health. Here in New Jersey, there's a complaint line where you can launch a complaint, and that complaint would be investigated through looking at the regulations and the requirements of hospitals. So that's another avenue. The other avenue that you can look at is directing people to, what would be the equivalent of consumer affairs, right? Because in New Jersey, consumer affairs oversee all of the licensing boards. So if there's an individual for which you felt that you were unjustly treated, you can always launch a complaint with the licensing board for investigation. So what I'm describing here is the ability to make a complaint at the facility level with whatever type of patient experience, patient satisfaction, patient advocacy unit that they may have. Then there's the opportunity to take it to the state so that the state can do an independent facility review. And there's an opportunity to take it to the licensing board for any, licensed or registered healthcare professional so that there can be an individual investigation. And so I think that all of that is there, just the village mentality of understanding what the resources are when other folks aren't hearing Black women, for you to hear them, for you to be able to link them to resources. When you don't have the answer, to work with them, to put them in contact with someone that has the answer. And I think that that's where we start.
Great, thank you, Dr. Anderson. And I think the great takeaway of this is that we need to listen to mothers, especially Black women and women of color. They know their bodies. They know when something is wrong. So at all levels, a friend, a partner, a coworker, you should be there for them, listen to them. If they have any concern that something is wrong, they need to, see their provider, find a better provider if it's not satisfying their needs. So I think that's a great take-home message, that we need to listen to Black women. And the CDC has launched an initiative called Hear Her, which is for all women, but we're going to share that with you here. We're going to be sending you the PowerPoint presentation as well with other resources, but here's a link to 3 great organizations, the CDC with their Hear Her initiative, some articles, great books for you to read if you're interested in learning more about reproductive justice and, Black women throughout history and medicine. If you have any additional questions or you're interested in receiving individual SEBA or training, please do not hesitate in contacting us. My information is here. Please join us for our second session. We're going to be focusing on the health determinants of health for Asian American, Native Hawaiian, and Pacific Islander communities. It's going to be a great session with 3 different organizations across the United States, and we're going to be partnering with the Asian and Pacific Islander American Health Forum. That's going to be in January. And our upcoming sessions for this Raising Voices series include human trafficking, transgender competency, equality care, and refugees, health needs, and other needs and awareness here in the United States. Yes, somebody asked me to go back to the resource slide quickly. And we're going to be sending the PowerPoint, so all of this is clickable, so we'll take you straight to that. And unless anybody has any more questions, we want to please make sure that you complete the short evaluation once you close this. And thank you, everybody. Any more questions? Let's see. I don't see anything. Dr. Anderson, we want to thank you so much for all of this very important information. If anybody has a question for Dr. Anderson, please contact me, and I will be more than happy to forward that information. You can find her as well on LinkedIn. And Dr. Anderson, you want to say a few last words before we finish?
No, I think that's it. I enjoyed giving this information today and hope that you find it useful. And, thank you for your participation. Have a good rest of your afternoon.
Thank you, everybody. Thanks for joining us, and we'll see you in January.